privilege for me to introduce Dr. Cole to you today. Dr. Cole received his BS from the University of Texas Health Science Center in San Antonio in 1993. He's been practicing biological dentistry ever since that time in Austin, Texas. He became Ozone certified in 2006 and received both his board certification in naturopathic medicine and his degree in integrated biological dental medicine in 2010 from the American College of Integrated Medicine and Dentistry. Dr. Cole received his fellowship in the International Academy of Oral Medicine and Toxicology in 2008, and he drafted the Academy's fluoridation brochure and the official scientific review on ozone use in root canal therapy. He has been featured on numerous radio and television programs, including World News Tonight with Diane Sawyer. He has been published in 3 national publications for cosmetic dentistry and lectures on practice management topics. I think we're in for a real treat. Please join me in welcoming Griffin Cole.
Thanks, sir. Appreciate it. I see you. Thanks. Can y'all hear me okay? Can you maybe close those doors over there too, so we get distracted? Okay, thanks for having me. First, I just want to start by saying that this is not a condemnation on cavitation surgery. I just don't perform them, so I wanted to seek out an alternative treatment for this. So that's what this presentation is about. I've actually got 3 cases that I want to show you. 2 that we treated with ozone therapy that were very successful, and 1 that I think might have been treated differently had we done ozone initially instead of doing the surgery. So let's just get into this. So I wanted to show, I've been doing ozone since 2006, and each year I've done more and more and more, and I'm finding that there's really nothing that I can't treat now with ozone. So these are some of the benefits of ozone therapy. I don't need to read them to you guys. It's, there's not a whole lot of armamentarium, assuming that you have the actual ozone machine. You may improve other all kinds of systemic issues going on. There's no post-op meds required if you handle it correctly. How can you do wrong by providing oxygen to all your tissues? It's very cost-effective, doesn't take long, it's non-invasive except for maybe an injection here and there. So there's just a whole lot of benefits. And really, I think only one disadvantage: you may not get rid of all the infection. And that's really the only one that I can find. On the other hand, we got quite a few disadvantages to cavitation surgery. It is invasive. It's typically expensive, time-consuming, obviously. A lot of armamentarium. There's a lot of instruments involved, obviously, in any kind of surgery. Post-op issues are more likely because it's a surgery. Meds probably required most of the time, I would imagine. You have to see them again to see how healing's going on and all that. And what I would call as the last option may not truly be the last option, so it may not get rid of all the problems. The benefits are you may get rid of all the infection and you may improve other systemic issues. So both can have the same benefits as well. So let's get into this. This is the first case. This is a 62-year-old female. Nice lady. She actually had been to see a couple other dentists before me, so this is kind of a neat case because we can follow it along. You're not going to see much on the Panorex, but up in the number 13 area, if I can get this to work, is where the issue is being treated here. So this is just a 2-dimensional PA, and I'm not, I'll admit that I'm not very good at seeing where there might be a problem right here. Maybe you could draw it around here and say this is the area. I don't know. I mean, because again, I don't treat these. I don't have a cavitat. I don't do any of that stuff. So to me, I need to see either a 3-dimensional cone beam film of the bone so I can look in every direction, or I need to actually see something blatantly obvious. So here's the history here. In 1999, she's exposed to trimethylbenzene. It was in a hotel, and I guess they were refinishing something in the roof, and she was there that night singing and was exposed to it. And then she says from that day on, it was literally that one night, she started having just a slew of problems. Long list of health issues, too long to go into, but one of them was tooth and sinus pain. So in the years between 1999 and 2005, she had quite a few teeth root canaled and then subsequently removed because that didn't help her problems. So in 2005 is when she had 13 extracted by a trained dentist, very skillful dentist, and the area properly cleaned. So they cleaned out the ligament, they probably did the little bone removal and all that, did everything right to prevent a cavitation. So now we fast forward here, October 2011, the patient gets that area surgerized for a diagnosed cavitation. So had the extraction done properly, heals up, goes about her life. I guess she's still feeling issues up there, sees a biologic dentist who says, yes, there's a cavitation, and does the surgery. We go forward a little bit further here. In 2012 of March, so this year, patient has it resurgerized for the same issue. The dentist had felt the area had not healed, and that's probably true. So I'm very grateful to have these photos from the second dentist, surgeon, and there's the cavitation, so it's there, I can see it. This is when they uncovered, can y'all hear me? It seems like it's going out every once in a while. Oh, you got it? Okay. This is when, you got it? Speak louder. Speak louder. So this is uncovered, so I don't know if this is the start of the surgery or this is what they uncovered and saw. So let's just assume it's what they saw. And then I guess this is a more close-up shot. I wrote completed surgery question mark because I don't know. That could have been midway through, but you can see that hole's gotten significantly larger. Probably the size, I would imagine, of our fingertip in there. Okay, so now she's in my office to see if maybe we can do something to maybe avoid any more surgeries, basically, is what her comment is. So this is my plan. And I always preface it by saying you may end up needing surgery anyway, but why don't we try this first and just see? Because you can always check your work, you can feel it, you can take x-rays, like I said, see if the bone's actually filling in, and how the patient feels as well. So real simple injections. For those of you who don't do ozone injections, I highly recommend that you get into it because it's a simple way to treat a slew of issues. All I did here was inject into the actual site. You could feel it. When you rubbed across, even without rubbing, just looking, you could see the indentation. It was definitely concave. So I put a little bit of numbing in there, and then I injected 3 cc's of 25 mg per liter of ozone right into the site. And you do it slowly because you could overwhelm them. That's the one time when they're going to feel some warmth, and if you do too much too fast, it's not going to turn out good. They won't want to do it again. Sorry? 25 milligrams per liter, 3 cc's. How many gallons? 20? 25 gamma, yeah. I also like to do an injection back in the PSA. I don't know if you guys got to attend Schallenberger's meeting in February, but it was interesting to see the guys that aren't dentists and how they were doing these was through the face. They were so excited about how they could inject through here, angle it around the bone, and get it back in that area. And I thought, we just go right in the mouth, right behind where the wisdom tooth is, and get right in that same area. So I would do that as well. And my thinking was, I just want to cover all my bases. I figure if I go back there, get the sphenopalatine, otoganglion, pterygoid plexus, whatever I can get back there, it's got to help. But even if you didn't do that, just going into the site may be enough. We're still too early in this to know if, to have enough cases to show, maybe comparing exactly that, apples to apples. So we did 9 visits between May and August. There's no rhyme or reason in my thinking of timing. It was what worked between both of our schedules. But it was approximately every 10 days, let's say. And she'd come in, and that's all we would do. Now, on a couple of those visits, she did also do some nasal insufflation. So to give full disclosure here, we would also run ozone through olive oil, and she would breathe that. Okay, it would be like for about 22 minutes, the same amount. Okay. So the results, I'm going to give you what I observed, objective views, and then we'll give her results, her subjective views, and then I'll show you actual films here as well. So the bone feels like it filled in. As you rub your finger across, you don't feel the indentation as much. It just feels solid. And the scan here, which I'm going to show you a couple different views, does everybody do 3D in here, or do a few of you do 3D scans? Yes? Show hands? Okay. So, there's a slight learning curve with that because you got to learn how to manipulate the actual software so that you're making sure that you're in the right place, because you can move it any way you want and say, look how good this looks. So I was really precise about showing you, and I'll explain as I go through here. This is an axial view, so we're going coronally, apically. And as you move the scanner down, you're getting to about the mid-root level, which is where that was. If you remember, it was on the buccal area, about mid-root. So that's what I have to do, is I have to determine, am I about where the molars just bifurcated or trifurcated? That's about mid-root there. Now let's get a closer view because that's so far away. So there's a closer view. So it's this area here. As you blow this up, it's obviously going to get more blurry, so just know that that's not your eyes. So this is definitely filled in with pretty solid bone. Remember, this is a 3D scan, so we're able to turn this thing in all views. I'm going to show you the tangential view, which is from forward going back. So what you do is, as you're sliding your mouse to go through the teeth, you have to make, and it shows you on a skull and all these different areas exactly where you are. So what I'm exactly in the middle of the 13 site here. So this is 14 that you're seeing in the background. We just went through 12. So this is the buccal part of that bone. This here, this is the palatal part. I don't know if that's just how the bone looks there. It's very possible. I don't have a pre-op scan that was done on a 3D, but the area where it was indented was right here on the buccal. So I think it looks pretty good as well. So this is her explanation of how things are, and this is subjective because this isn't necessarily science, but she feels that the area is healed. Less migraines, the first time, she says, in years that she's not having them on a regular basis. And I didn't know this because she didn't share this with me, but she said this is the first time that she doesn't need painkillers on a daily basis for the first time in 10 years. So I said, can you explain what you mean by that? And she said, oh, I would take at least a Vicodin or two each day just to get through this discomfort. So I probably should have done a better job initially with getting this information because this would have been more exciting to me at the time. And then she said this was her aha moment. And if you know this lady, she's very animated and very intelligent. And she said this was my aha moment. This is when I felt you got it. I feel better now. So that last treatment was. Those images that I took, actually, if you look there, I don't know if the dates are on there, but this was done early this month. So, August, mid-August. So less than a month ago, these films were done. So this is very, very recent. So great results. I don't know, had she had ozone initially, would she have even formed a cavitation? I don't know. I think that, now if I extract a tooth, and I don't do a whole lot of extractions, but if I do them, I will irrigate the area out after you clean it and drill. Irrigate with ozonated water, and then I'll do ozone gas in there and just put gauze over it, and that's that. Now, you can go further and give them like a gel that's ozonated. I prefer one with jojoba, which I'll talk about in just a little bit, but, that's how I would do it. So, go ahead. We're going to try to do questions at the forum. Is it real quick?
Bone graft. If you put a bone graft in the
I don't, and I never have, and it's my own. He was asking if I'd put a bone graft in there, and I personally wouldn't. I don't want anything artificial. Now, if it's from her, which I wouldn't do, but if it was shaved off and mixed up with, blood factor and put back, that's a whole different story. So it's just a question. Would this have been healed and done fine had ozone been done initially? I don't know. But we got great results. Remember, she was surgerized 3 times, guys. The initial surgery for the extraction and 2 cavitation surgeries. So a lot of efforts were made by skilled people. Okay, case 2. This is a bisphosphonate case. Yeah. I didn't catch that all, Phil. I'm sorry.
It doesn't look like there's a lot of bone gone from there, and some of the cavitation surgery
Made it worse, you mean?
thorough, you think, the previous cavitation surgery.
I don't know. That, I guess that was my issue early on, was that, so I'm going to go into an area of dead bone, I'm going to drill into it to get it all out, and then we'll get primary closure, right, with sutures. Are we really keeping that area fully clean? I don't know. Again, I don't do cavitation surgery, so I don't want to make any judgments on it, but that's a good question. The surgery definitely took out more bone, I assume, because it's dead. It's some kind of necrotic state, so they drill it out until it's solid and then close it up. So, and I don't believe any grafts were done in that, which is, again, that'd be my choice as well, not to do grafts. So, that good? Okay. So bisphosphonates, is everybody somewhat familiar with bisphosphonates? Because that's a whole lecture by itself, so I don't want to get into that all, except to say that, these are medications that are basically osteoclast inhibitors. They form bone, basically. The problem with the jaw is that we have such turnover so rapidly every year that area gets traumatized just with simple mastication, brushing, flossing, whatever, that it leads to problems. So it used to be, and I'm now seeing this in my own office is not true, but it used to be this was an issue for someone who was on them for 10 years or did a lot of IV bisphosphonates. And I was just telling Phil Mollica today that I got a patient, granted, breast cancer with mets to the bone now, got put on an IV one, and in 3 weeks formed an osteonecrotic site. 3 weeks. So, I don't know what to say about that, but I think those numbers need to be changed in the literature, because they're saying it's, I'll show you those actual figures in a second, but it's very, very low rates of osteonecrosis, and I just don't think it's true. I think we're going to all start seeing a lot of this. So I'm including this for two reasons. One, it's a great case. But two, wouldn't this be like the ultimate cavitation? I mean, if your bone is necrotic and dying off, that's pretty much what a cavitation is dead bone. So I think this is a really cool case to show. And for those of you who are at Schallenberger's meeting in February, I apologize because you've seen this. So let me just get this whole slide up here. So the definition of BRONJ, which is bisphosphonate-related osteonecrosis of the jaw, is exposed bone, with no history of radiation therapy, because patients undergoing that therapy can also get this. It's very different. The bone has to be exposed for greater than 8 weeks. I don't know if I believe that. Again, I'm seeing it. I think you can diagnose it much sooner. And these are the things that they say it's related to, but quite honestly, the last one is probably the best one, is that this is so new that I don't think we truly know everything that's caused this. We know the science. We know about the bone turnover, which I'll show you on this next slide, but we don't know everything of what causes it. Most of the literature says it follows surgery. They had some kind of dental surgery, and so now the bone is exposed. And I don't think that's true. I think that can happen that way, but we're seeing it just, again, from everyday trauma. So here's the science that we do know about the bone turning over quite a bit. It's mostly in the mandible. Most of the cases, all the cases I've seen have been mandible, except for this one that was 3 weeks. That was maxilla. Again, 60%, some form of oral surgery they had done, and then all of a sudden they've got this exposed bone. The oral flora is conducive to bacterial problems because it is so thin and easily traumatized that if you get any kind of nick or opening in the wound, it's going to just exacerbate this problem. This is the risk that they're showing right now in the literature. So IV, 1 to 12% over a year, and oral, very low over 3 years. And again, this patient that I have, not this case, but this other one, 3 weeks on IV, and already has it showing up. So, and by the way, too, there's no real benchmark treatment for this. I mean, what we're doing right now, what I did on this case, thanks to my mentors, is pretty new. The only thing that I've seen in the literature at all is by one doctor who just mentioned that ozone seems promising, ozone with antibiotic therapy. This case that I'm going to show you right here was only ozone. That's it. And you'll see how dramatically this heals. These are courtesy of Phil Mollica. These are just some other examples of what it looks like. I'll show you hers in a second, but these are pretty advanced cases here. Again, I would think that these, I don't know if Phil treated these or not, but I got these slides from him. So thank you for that. IAOMT is the guy that's in the literature who mentioned that ozonized oil with antibiotic therapy looks promising, is what's been written. So we're going to work at getting this thing in there. So these are the current forms. You do nothing. That's probably the #1 choice because you definitely don't want to do any surgery. And that's, where is it? Right there, yeah. avoided. Any kind of debridement of the site is very avoided because it's just going to make things worse. Plus, it's extremely painful. Stop the bisphosphonate treatment altogether. That's probably what a lot of doctors will do, is just stop doing it. Or they'll alternate. Let's get on it for a while to build the bone, then let's stop so we can avoid these issues. Let's get back on it. Palliative treatment, they hurt. So pain meds, maybe a Paradex rinse or something like that would be a treatment of choice. And then the last one. And here's where, again, I think we're the pioneers. We're the ones who should be doing this kind of treatment and maybe getting stuff out in the literature to where this becomes the standard of care. Or we just stop doing all bisphosphonates altogether. So this is the treatment of ozone, getting real specific with why it works so well. Essentially, it forms antioxidants, it prevents free radicals, and it increases blood flow to the site to get healing. That's really it in a nutshell. So you guys can read that yourself there. I don't have to go through that. Reepithelialization of the soft tissue over the wound. I'm going to show you how that actually happens in this case. You literally see healing happening while the piece of bone is still falling out. It's like healing underneath it. It's pretty cool to see. So this is the case, and I want you to look carefully at this because it's not just that area there. So this is in a mirror. It's her lower right. So that's 28, 29, 30, okay? This is what she appeared with, but if you look back here, and right here, you'll see two almost little fistulas there. And you'll see here in the end that it is that extensive, that it goes all the way from here to here. But she comes in and she has this, and she says it hurts. And she met with Bob Harris initially, and then she moved to Dallas. And so Bob had her come see me. And we did only 4 treatments, which I'll show you, in a pretty short time. And you'll see how this thing was treated. So here's just a simple periapical, just a 2-dimensional periapical that we took, just to have that as well. You know, when you look at this here, at first I thought it was maybe, you know, the actual lamina dura or just the PDL being actually affected, but I actually think what it is the view of the area behind the tooth, lingually to the tooth, I think is what I'm seeing here. I think it's just we got right dead on there, you know, and that's where most of the area was. Okay, so this was the actual work that we did. It was supposed to be more than 4 treatments, but she came from Dallas, and this is what she could do. So we did 4 treatments over 6 months: June, August, October, and November. Again, site injections. I used a 30-gauge short needle. You can probably do just as well with a 25 gauge and probably get your work done even more efficiently, but she was so sensitive that even with a little bit of numbing, I still wanted to be as gentle as I could be. Again, 3 cc's there directly into the site. I actually went to where you saw those 2 little fistulas. I did both those areas, and then I did, I tried to do directly into it, but obviously you don't poke the actual sequestrum, but you try to get maybe underneath it a little bit here. So we did that, and then I would immediately follow with ear insufflation. I don't know how many of you guys do that, but it's really quick. It's like 4 minutes. You take a stethoscope and get some damp gauze, put it on the earpieces, put it over the ears, and flow your ozone through there. And then nasal insufflation. On the ear, too, it's a lower dose. What gamma do you guys do, Bob? I set mine at like, you know, maybe 10 mgs per liter. I don't know what you guys do higher than that, or?
No, the normal dose is between 10 and 20.
Okay.
That's longer than that range.
Okay. So we would do ear, and then we do nasal, and then she always brought a jug of water, and she'd ask me to ozonate it, and then I guess she would drink that for the next day or so. So that's what we did there. You know, one time, I should give, again, full disclosure here, but one visit I did try to do a little cocktail, and I don't know that I was really that successful with it, but it's a cocktail of B6, B9, B12, and a little bit of procaine in there. I didn't use any Tramil or anything like that. I just wanted to get some B complex in there, but quite honestly, I don't know that I really got that much in there because you know, there wasn't much area to do that. It was kind of just squirting all around the area. So I really feel like this is an ozone-only case. So that's just a picture of me injecting. Oh, that's probably right between, you can't see the bone right now, but it's right under the blood there. So I'm probably just right proximal to that. And you can see the pus coming out of both those sites that we saw earlier on there. So it's definitely getting in there and working, and she could feel that too. She was like, oh, I feel that. So let's fast forward here to November 2011. So this was the last visit that we had prior to her coming in for a final follow-up. And I'm excited because now I'm seeing this gum get a little more pink. You can barely see that fistula, and that one's gone. And also, too, one thing I should say, she would always leave the office with cream I had here, and they're actually here today. It's Ozone, which is, I like it because it's jojoba and ozone, not the olive oil, which you have to keep in the refrigerator. This stuff, room temperature, it's got an indefinite shelf life, it tastes better, it's got a great viscosity. So I would give her this every time and say, just be liberal with it. Rub it on whenever you think of it. Just rub it all over the area. And she did. She was very religious because I would give her little small sample sizes, and she'd go through that and say, I need more. So I just gave her as much as she needed. So you'll see in a second that probably had a very nice effect on that as well. So again, this is November 2011. I did a path report. It's not necessary. We all know what it is. It's basically, non-vital bone. But I wanted to do my due diligence and do the whole thing. You probably can't read that, but just septic non-vital bone. There's really not, I don't think it's necessary. We know what it is. And this was what she said this fell out the day after we did that last treatment. So can y'all see that? It's 3, 6, 9, 12, about 15 millimeters wide and probably 18 or 19 long. So one day after the last treatment, she said that she was in the bathroom and she said it felt really weird, and she just reached in and flicked it right off. And that's what came out. And she brought it and she showed it to me, so I was thrilled. So let's do our due diligence here and do our cone beam scan. So here's an axial view. I did take one at the start because I was starting this case, so I could do that. So look right here in this lower right area, and notice that I do my best to line these up. I mean, you're going to be off a little bit here, but I try to keep the same, basically exactly where I am, the same look here, the same look there, same size of the condylar. You try to get everything lined up as best as you can. But look right here. So this is the whole area. Remember, this is 28, 29, 30 area. This whole thing looks almost sort of moth-eaten, like you could almost snap it off. And that's exactly what happened here in November 2011. It's off. And this little spicule here is going to probably round off real nicely. So there she is. Pretty good. I mean, there's no hint of anything here. It's as pink as can be. So no surgery, no pain meds, no debridement of the area, nothing, just ozone. Pretty good case, and I've got let's look again at the comparison here. So this is just the month before. Remember, that was the last treatment I did. Next night it falls off. She comes back. I think it was about 3 weeks later. This was late November. This was mid-November. And I look in her mouth, and I'm thrilled. So really great case here. And again, this is the company. It's O3 Dental Cream, but Ozone is the actual cream I'm talking about. That's the old tub. The new one looks better. Incredible product. Quite honestly, I'm sorry? No. This is the company. Can y'all read that? O3 Skincare. You probably can't read that. O3 Skincare. Ozone. They're here this weekend. They're out there, so go visit them. Just incredible. I'm not 100% certain that the cream didn't do most of the work. I don't know, because she told me that she was applying it every day, and jojoba is an ester. It has its own healing properties when it's pure jojoba. And so you combine that with ozone, and it's a pretty powerful synergistic effect. So I don't have any financial interest in this, except I want them to do well because I think it's a great product, and I'm using it. Okay, let's go to case 3. This is a case that is now being treated with ozone, but was initially treated all surgically. And I'm showing this case only because I want us to all kind of make up a differential as we're watching this and think about how we would maybe handle this case, because I was the one that started this case. I bowed out of this case. Stuff happened, and then in the end, she's back in my office. So this is kind of a really cool thing. This is the initial visit was in 2007, and her chief complaint dentally was deep tooth pain. She would point to her upper right and say, I'm telling you, it's this tooth here. I've got a problem up here. I want you to pull that tooth. So I said, okay, let's take a film. Let's examine it. At that time, I didn't have my 3D, so all we had was our two-dimensional films to go by. I took a Panorex. I took a PA, palpated the area, percussion, all that stuff. I couldn't find anything. The tooth looked good to me. So I did the right thing. I said, look, I'll send it to my old surgeon friend because I'm not going to pull this tooth. it's hard for me to see what's going on. So let's just get a second opinion, and hopefully he'll find something and he'll treat you. So that's what she did. These are the chief complaints, that the teeth are causing all the problems: constant pain in the head, no energy, unsteady gait. I did actually see that from her when she always had help from her husband. And the bad chronic headaches was what she was convinced was from the teeth, because she didn't have them prior to whatever started this deep tooth pain. But she did have an MRI, and there were no findings on that. And then she had read some stuff about cavitations, and so this was her first step into maybe treating this, was let's get these teeth out. So again, I sent her to the surgeon. She sees the oral surgeon, and he extracts number 3. He said, I can see maybe some PDL widening on the film. I feel pretty comfortable doing this, so I'll go ahead and take the tooth out. So he does. So she has some relief, but she wants the next one removed. So he says, okay, he said, possibly she does react bad to percussion there. Maybe the tooth is a problem too. Maybe there's a root fracture. I'll go ahead and take that one out too. She likes it. She wants the next one out. So he says, I'm done. I don't want to take any more teeth out. So I'm sorry, but you'll have to go somewhere else. So 1 year later, she comes to my office again and says, look, I want to get these teeth out. Will you help me, because you're my dentist, and I'll sign whatever. I just want to get them out. So I said, wait a second. Have we gone to have we seen neurologists? Have we looked at everything? Endocrinologists, whoever you can. I don't want to pull your teeth out until you've done everything that you possibly can. So I said no. And so she sought out another one, very skillful biologic dentist, and this is what happened. So I'm not judging this case, because bottom line, patient agrees to treatment. Patient wanted this badly. I just didn't want to do it. So, you can sit back and look shocked at it, which I was, but as I think about it more over time, I realized that patient walked in there on her own volition, chose the treatment, and this is what she got. And so all the teeth are out. She's in dentures now. She didn't have bone for implant supported ones, so they're just dentures that she pops in and out. And they're not great. They weren't done by this dentist. They were done by somebody else. But so some of us might have an ethical dilemma with this. I don't even want to get into that. I just, for me, it was a matter of whatever evidence I could find. So is it my place to tell the patient that even though you think that your problem is your teeth, that I say it's not, and therefore you shouldn't do this? No, but you can refuse treatment. You can just say, I'm just not the guy for the job, so let's go find somebody else and do it. The downside is that after all this work, that she's better, but she's not 100% better. So she's back in my office now, and we're doing ozone treatments. So this is me doing an injection right into with an X-tip. You guys do the X-tip. It's great. You can put an X-tip in there, then you can put your syringe right into the X-tip and inject in the bone. So she's really specific about telling me, look, the only area that I really feel is still bad is the initial area. Remember, it was 2-3 area. So I find that interesting, because I wonder if maybe it was just, some freaky sinus thing or something. I don't know. But I said, okay, I'll do that. So we did injections. We did, between September 9th of 2010 and April 30th, we did 12 treatments. So, I don't know what that broke out into, but, fairly often, every 10 to 14 days or so. All to the upper right. Typically, again, 3, sometimes I'll do 6 cc, just depending on where we were going. It was always around the wisdom and number 2 area. I think I went up as far as number 3 at one point, just to make sure I was covering all the area. I even came from the palatal side a couple times. It just depended on what we felt like doing and what she felt like doing. She would sometimes do nasal insufflation as well, but pretty much it was all site injections. After the first one, you always get the wonderful report, oh, this is it, you finally did it, I'm running now, I could barely walk before, and those are exciting, but you got to wait and play that out and see if that still holds true after time goes on. I don't have the Cavitate, but this is a dentist in San Antonio who does, and she wanted to go get that done. And so, for those of you who read this, please forgive me if I don't know what I'm talking about, but I assume it's good to have less red, correct?
Yeah.
Okay. So this is January 27, 2010. I guess she's got quite a bit back here by the wisdom area and in the number 2 area, and this is just a few days, or just maybe 2 weeks later. So I guess that's good. It's a lot less there, although I see some red down here that I don't see here. So, she liked to get it done. I said, great, get it done. Let me get it in your records. And that was good. It was some confirmation, at least from a bone sounding standpoint. This is what I like the best, and we all like this, is when we get the feedback. And I quoted her exactly from an email here, so I will read that. But she said, after my last ozone treatment, I've had progress in my health. It seemed to have hit the mother lode of infection. My symptoms have been significantly reduced. I've even started walking around the block, in addition to other normal life functions, which I haven't been able to do for some time. I also went on a cruise with my husband, and I'm hopeful to be able to endure a flight to visit my grandchildren in Indiana. So everything's going great. She had mentioned that the one other thing that she had done was, I think she did one bout, maybe two, of some laser treatments in San Antonio. So I don't know if that was done to the same area or not, but maybe it was the combination of the two. Hard to say. This is the slides from Phil Marlica that got me into this, because I just don't know how to argue this case. So this is a patient that came in and they had a fistula on the palatal side of number 11, and had a fistula here. And so Phil, it was Phil or Bob? Bob. I'm sorry, Bob. Sorry about that. So Bob says, well, let me try this. I'm going to inject some ozone into that site, and let's just see what's going on. And look where it bubbles out. So distal to 15. So we're injecting at 11, and it's coming out there. So the question is, how do you treat that? How do you treat that surgically? Let's assume that 15 is the only problem, and the fistula is directly from 15, and for whatever fluky reason, it traveled all the way up to the palatal side of 11. Or maybe 11 has its own problem, which I know isn't true. Right? So this was it for me. This was the aha moment for me, was how do you treat that? I guess you could remove all those teeth and the bone, kind of like we had on the last case, and maybe you'd resolve the issue even with the same success. I don't know. I'm not a big fan of cutting when maybe we don't have to. There are times when you got to cut, but why not try a non-invasive, simple way first? See how it goes and give it a chance. Don't just do it once. You got to do, 4 or 5 visits over a certain period of time to see if you're actually getting healing, and follow up with films, hopefully a 3D film, and see what's really going on. Because I look at this case and I ask myself, is she really better off? I don't know. I mean, I don't, to me, she's fairly young still. This is obviously a younger picture, but, this look of somebody without teeth. And I had her take her dentures out, in all fairness here, because I wanted to see what the mouth really looked like. I just don't know that she's better off. So, that's it. Thank you. I think we might have time for just a couple questions, because 5 minutes, Dave goes on. The site injections, you know what, for any person I see, I'll start off with an initial fee, like I'll say the first injection is $95, let's say, or $125, whatever. Each subsequent visit, if they're coming in a certain period of time, I might knock it down to $60. I mean, I just try to keep it, when they're coming from multiple visits, I just try to make it to where it's very feasible, and they'll do it. They'll be compliant. So, yeah, typically, just real quick on that part too, you can determine that however you want to. If you think it's worth $500, I do too. If you think it's worth $1,000, I do too. I just don't charge that. So, yeah. Good question. For, my fee for the first time for 22 minutes of insufflation, you're going to pay probably $225. Your next visits will probably be down to $125, maybe $100. So again, just depends on how many. If somebody comes in and they go, look, I just want to do it one time, it's $225. If you're going to do 5, 6, 10 treatments, then I'm going to make it feasible. But that does, that's 22 minutes of ozone, so you got to get your money back on that. Yes.
Have you had any experience with radiation necrosis?
I have not. Radiation necrosis, I haven't. This was truly a bisphosphonate case, as well as that new one I'm saying. Did you have your hand up?
Yeah, the third molar area was, are you handling the cavitation?
Well, again, if somebody comes in and they say, hey, I've got a cavitation in this site, and I do a 3D scan and I see it, then absolutely I'm going to say, well, you know what, there's some great surgeons real close to me that you can go see. They're awesome at that, but why don't we try this first? So I'll do the injections. Yeah.
How do you do it? Would you give them a lower block of the ozone?
No, no. I'll get the area numb first, however you want to do it, and I inject into the site, right in the site. So X-tip, you saw that picture of the X-tip? Yeah. Now sometimes when somebody has like on that one case I just showed you, some days I could just go in with my needle. It was, you know, when she first came, it was just soft. So don't waste your time on an X-tip. But once it starts to get a little bit stronger, or you're moving up to other parts of the bone where you got to get in the bone, then you use the X-tip.
Anytime you're doing the injection, you give some